think. I don't know. I'm waiting for Gordon.
Okay. I'll wait for the signal.
Sorry. You guys sat down and everybody got really quiet. Good evening, everyone. Sorry, I misunderstood my cue. Welcome to tonight's Lung Cancer Living Room, brought to you live and in person from South Florida. We could not be more thrilled to be here. I'm Danielle Hicks. I am Chief Patient Officer at GO2 for lung cancer, which is just a really fancy way of saying that my job is to provide all the support and education services that GO2 has to offer, and this is a signature program. For those of you who might not be familiar with the Lung Cancer Living Room, it's a support and education series built with patients and caregivers at the center of it. So we built it for you to bring to you live and in real time conversations from key opinion leaders like this amazing panel you're going to be hearing from today, and giving you access to them that you might not otherwise have access to. So we do a live in person. We have live streaming for those who might be watching from their own living rooms. And this is a special regional meeting that we've been doing, Dr. Raez, for 16 years, I think now, yeah. So we do this programming regularly from our corporate offices in California, where all of you can also sign in on the third Tuesday of every month. So if you want more information about that, we'll be sure to let you know. But this is a very special program brought to you all by a really incredible team, and I mean this from the bottom of my heart. We met the team from MCI going on 20 years ago. And when I say that multidisciplinary teams that could potentially hold a candle to the folks you're about to hear from tonight, those are few and far between. This team, this is not just a job for them. This is a passion for them. They care about what they do. So with that being said, one of the things what we're going to be talking about tonight are challenges that come along with managing lung cancer across multiple disciplines. Lung cancer is an incredibly complex disease. The good news is we know more now than we ever have, right? But along with that comes, how do these folks all work together to ensure that you are getting the best care for you? So with that, I am super honored. Before we get started, I want to remind everybody that because this is for you, please raise your hand if you have a question as these amazing humans are talking tonight. Please just raise your hand. We'll bring you a mic. Again, this is for you. There are no stupid questions. So anything that might come to mind, please, please, please feel free to ask. And with that, and before we begin, I'd like to introduce Memorial Cancer Institute's Commissioner Violet Lowry to stand up and say a few words.
Good evening. Good evening, and thank you, Danielle. On behalf of the Board of Commissioners and the entire Memorial Healthcare family, it is my pleasure to welcome you to tonight's Lung Cancer Living Room program, Challenge of Multidisciplinary Management of Lung Cancer. Thank you for joining us this evening, and whether you're here as a patient, family member, caregiver, healthcare professional, or community member, your presence reflects something that is at the heart of healthcare. The belief and the knowledge, collaboration, and compassion can make a real difference in people's lives. Lung cancer remains one of the most challenging diseases we face, which is why programs like this are so important. They create opportunities for learning, meaningful discussion, and connection between the people providing care and the people whose lives are impacted by it every day. I would like to extend a special thank you to our distinguished speakers and our moderator, Dr. Luis Raez, for sharing their time, expertise, and dedication with us this evening. We are fortunate to have such an outstanding team here at the Memorial Cancer Institute. As a commissioner, I am proud of the Memorial Healthcare and the Memorial's commitment to providing world-class cancer treatment right here in our community. Tonight, I would like to share a more personal perspective. I have had the opportunity to witness firsthand the care, compassion, and professionalism of our Memorial Cancer Institute team. They treated a loved one of mine, and they are still treating her. And what I observed not only is the exceptional medical professionalism, but also the genuine kindness and support during a difficult time, which I'm sure that all of you can understand. Because of this experience, I can say that the Memorial Cancer Institute is a place of hope. It's a place of hope for patients, for families, and hope through innovation, collaboration, and outstanding care. Better outcomes are possible. Tonight's topic highlights our important reality. Lung cancer care is rarely the work of a single physician or a single specialty. It requires coordination of team of medical oncologists, surgeons, pulmonologists, radiologists, nurses, navigators, and many others working together on behalf of each patient. While that collaboration brings tremendous opportunities, it also presents challenges. And that's exactly why tonight's discussion is so valuable. Healthcare is at its best when expertise meets humanity. And tonight's program is a wonderful example of both. Thank you for being here. I hope that you find this evening's discussion valuable. And thank you all for supporting the Memorial Cancer Institute, the Memorial Healthcare System. And thank you to all of you. Have a great night.
Thank you so much, Violet. So I'm going to turn it over to Dr. Raez, but before I do, I just want to remind everybody, please, 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 this is a conversation, so ask questions. You have the whole lot here, and it's meaningful. So Dr. Raez, before we begin the program, if you wouldn't mind introducing yourself and then everybody else.
Yeah, thank you. Thank you very much for coming tonight. First of all, my name is Luis Raez. I am the honor and privilege to be the medical director of Memorial Cancer Institute for the last 14 years. But in the daily life, I'm also a thoracic oncologist, a medical oncologist, an expert in lung cancer, and I have had the honor to meet a lot of you and treat you. And tonight, we are here with the Memorial Cancer Institute, but also with the GO2 Foundation that Danielle and the ladies represent. For me, this is a very important thing because we create this partnership more than 16 years ago. And I want to honor the memory of Mrs. Monia Dario, the mother of Danielle, and she was a lung cancer survivor. But after surviving lung cancer, she found that there was not enough to survive lung cancer, so she has to make a difference in the lives of the other 150,000 lung cancer patients, 250,000 patients, lung cancer patients that we get every year. So that's why she created this amazing foundation, and with this foundation, we do a lot of educational events, partnership, advocacy. You know, you guys also come to our 5K once a year here outside in Hollywood Boulevard to fundraise money for lung cancer. So it has been an amazing partnership, so we'll always keep Monia Dario in our heart, in our mind, and thanks to her, we're here. They also want to give thanks to our industry partners. You know, we have here people from J&J, we have people from Innovation Bio, and we appreciate the fact that you support our events, and without industry we cannot do anything. Now we're going to introduce ourselves, so maybe we can start with in the right, Laura.
Yeah. Hi everyone, thank you so much for being here. My name is Laura Ramirez. I am the Lung Cancer Navigator on behalf of our Memorial Cancer Institute. I am also the Multidisciplinary Clinical Navigator. I've had the privilege of working directly with Dr. Raez, He was great in teaching me in lung cancer awareness, the treatment plans, and moving forward, and it's been a great experience. And I hope to continue to grow and to guide and to educate our patients moving forward through their lung cancer awareness.
I'm Dr. Ignacio Castellon. I'm the medical director of radiation oncology at the Memorial Cancer Institute. I've been at Memorial for the past 16 years, and I've been participating in this multidisciplinary group, and I've seen a lot of familiar faces, so thank you for coming. And I always enjoy doing this event where we get to see patients and interact with the community in regards to what's, the latest updates in the treatment of lung cancer.
Good evening, I'm Mark Block. I'm the chief of the Division of Thoracic Surgery. I've been here for about 20 years and now have the privilege of heading a team of 4 surgeons, and we work very closely with everyone up here. Oncology, pulmonary, radiation therapy, social work, all the support services to help provide the best and latest in diagnosis and treatment for our patients with lung cancer. It's a pleasure to be here again this year, to see a lot of familiar faces, and to really be a contributing part of this community. Thank you.
I'm Dr. Gelenis Domingo. I'm a thoracic oncologist at Memorial Cancer Institute. I've worked for Memorial for the past 10 years. I appreciate all of you guys coming out, and hopefully we have a good session and we can answer some of your questions tonight. Thank you.
My name is Brian Gotkin. I am the medical director of the adult pulmonology group. I've been in Memorial System for the past 26 years, and I've been a part of Memorial for the past 7 years. I initially started off in private practice and then became part of Memorial System. I've been here for 26 years, but I've actually been here longer. My father was a physician at Memorial many years ago, so I grew up in this neighborhood. I also help run our incidental and screening lung nodule program, along with our nurse navigators and the thoracic surgeons. And I've been working with this group of doctors for a long time, and they're all great doctors.
Hi everyone, my name is Paul Hakimata, and I run the Molecular Diagnostics Lab at Memorial. Our main partnership is of course with the Cancer Center here. We diagnose most of the different cancers that we test for, and we try to match them with the different drug recommendations that we can give targeted medication for you guys. It is my pleasure to be here. I normally work behind the scenes, so I don't get to see any of the patients. So for me, this is very rewarding.
Okay, so now, as Daniel said, this night is about you. It's about our patients. We love, sometimes when we see you in the office, we're in a hurry, we only have 20 minutes to see you, and I'm a patient too, so that's when you go to your doctor, they don't have time to see you. That's why tonight we have time. That's why we are happy to answer any questions, any comments, and until you warm up, we are going to briefly describe what each of us do in the daily life in the lung cancer care. And then after that, I will start to ask for some comments, opinions, or questions that, as Daniel said, any question is valid. If you can ask us, if we discover the cause of the cure for cancer, we will answer you. We will answer anything that you want, because that's what this is about. It's a dialogue. So that's why now, until you warm up, you can drink. There is some wine there. And we're going to start with Laura. But can you describe what is the role of a navigator in the multidisciplinary team? What do you do?
So as a lung navigator, I've actually had, how I said previously, I had the privilege of working with Dr. Raez, so I see a little bit of a different component. So I do the initial contact prior to the initial visit. And I'm aware, and I have to remember just to be compassionate, because I may be speaking to someone on the worst day of their life. So I have to remember to be compassionate and just guide them through it. Just let them know that they're not alone on this journey. I will help them through the process. I collect the records in terms of images, pathology. But aside from all the record collection, I just want to make sure that our patients know that we're here to guide them through the journey, and that I will help them any way that I can. And moving forward, I just hope to continue to learn to do my job as best as I can.
Great, thank you. So Laura is the navigator. So I guess for most of you, is the first person that you met in the team before you come to meet our surgeons, radiation, or medical oncologists, no? Dr. Castellon?
So as a radiation oncologist, I work with the team, and essentially I evaluate patients and determine that based on their stage and their diagnosis, whether they would benefit from a course of radiation, and specifically what type of radiation treatments there. There are many different techniques and many different modalities that we can use with radiation. And so you may hear of some patients saying that they may have gotten what's called SBRT or stereotactic radiation, where maybe they get treatment in just as little as 1, 3, or 5 treatments. There's some patients that benefit more from fractionated radiation, where they come in daily over 5, 6, or 7 weeks. So largely, we collaborate with the team here and try to determine based on the patient's clinical stage and diagnosis what's going to be the best treatment plan. I think a question I get quite often is if I'm the one that actually delivers the radiation, and I always tell patients to think of me more as an architect. I generate the plan and then I execute it with the team. We have a team behind us between the therapists, physicists, dosimetrists, and I oversee that team. But as I always tell them, you never want to have the architect running the bulldozer, because they might knock down the wrong wall. So I'm not the one that actually pushes the button to treat the patients, but I oversee that whole process.
No, yeah, that's a good analogy.
Yeah.
It's the same with me. When they said, do you give the chemotherapy? And I said, no, I don't know. I never give chemotherapy in my life. I always write the order, but you have an expert nurse that knows to calculate your weight, your height, how many cc's, and et cetera, no? So that's why we're very proud to have a great team. Mark?
So we actually do the surgery.
Yeah.
As thoracic surgeons, we're intimately involved in many phases of the care of a lung cancer patient, anywhere from a patient who presents with an unknown lung nodule. We're intimately involved along with the pulmonary team in getting a diagnosis, in doing the staging, in other words, assessing for whether it has spread to regional lymph nodes or other parts of the body. And then if the patient is appropriate for surgery, we help make the decisions about type of operation to do, which operation to do, and how best to do it. And then hopefully we get it done quickly and safely. And one of the, I think, big developments over the last several years has been the technological improvements in the way we do surgery. When I first started training 30 years ago, pretty much every lung cancer operation was done with a thoracotomy, which is a big incision, goes around the shoulder blade, you go in between the ribs. And nowadays we do it through little tiny incisions. It's been a progression from the open approach to thoracoscopic, kind of like arthroscopic surgery with cameras, and now many of our operations are done using a platform that people refer to as the robot. And I want to ensure everyone is really not technically a robot. It does not do anything on its own. The surgeon actually sits at the console and manipulates all of the instruments and does the entire operation. It's not like we sit there and push a button and watch the machine do the operation. So we actually do it. And along with that have been developments in postoperative care. So, when I was in my training, people were in the hospital 5 days, 7 days after surgery. Now, very often our patients are going home a day after surgery. So faster recovery, shorter hospital stays. And those things are important not just in terms of quality of life, but they're also important in the multidisciplinary care. That means patients are in better shape to see Dr. Raez and Dr. Domingo and get their adjuvant therapy. And if you're in better shape to get your adjuvant therapy, that means the therapy is going to be more effective. And the same thing with Dr. Castellon. We collaborate very closely with radiation therapy so that we are complementing each other and improving quality outcomes. So that's a little bit of a spiel on what we do as thoracic surgeons.
I have a question for you, because now that you're talking about the robots, now you guys have also robots for diagnosis, no?
So yeah, the term robot is kind of a shorthand for systems that use a lot of computer control. So one of the techniques that we work with Dr. Gotkin on is diagnosing lung nodules. And there have been a number of ways to do that over the years. Historically, it's been through what's called a CT-guided biopsy, which is a needle that goes through the skin. Patient lays on the CT scanner table, and they can get a sample. It's a reliable test, especially for tumors that are larger than a centimeter. And at our institution, where the interventional radiologists are extremely capable, it's very good, it's very safe. But there are situations in which it may not be the optimal approach, and so we have technology now that's thought of as a robotic bronchoscope. It's actually the 4th or 5th different generation. We've been using these kinds of what are called navigational bronchoscopy systems for many, many years. And the concept is that we try and go through the mouth into the airway, with the camera and work our way out into the part of the lung where the tumor is to take some samples from the inside of the lung. That has several advantages. It doesn't risk puncturing the lung. We also are able to sample lymph nodes, sample nodules in different parts of the lung. Typically with CT guidance, they just do one nodule, and if there are 2 or 3, the other 2 get ignored. We can sample all of those at the same setting. And the other advantage is that we can use the ultrasound, which enables us to sample the lymph nodes. Those of you who've had lung cancer and know about it understand the importance of the lymph nodes that are in the central part of the chest. That has to do with staging. So we can do a procedure where we navigate with the bronchoscope, sample the nodule in the lung, we use the ultrasound to sample the lymph nodes, and so in the space of an hour and a half, we have the diagnosis and the staging. And that's essential if we're going to get patients from their initial abnormal X-ray to their treatment as soon as possible. The robotic bronchoscopy platform, as I mentioned, like the surgery, it's not really a robot. It doesn't do anything on its own. It's all controlled by the surgeon. What it does, or by the pulmonologist, it takes the CT scan, which is a 3-dimensional digital image, and it creates a virtual image so that when we're doing our bronchoscopy, even though we can't actually see the tumor in the lung with the scope doesn't go out far enough, we can look on the screen and it has an augmented reality image where we're looking at the tumor in relation to where our camera is. So we can point the camera directly to the tumor. We can't see the tumor, but the computer shows us where it is. So it's this kind of augmented reality system that you're probably familiar with, and that's how we're able to get these samples safely and with a pretty high degree of accuracy. So that's another one of the important technological developments that folds into our multidisciplinary practice.
Great. So maybe you can tell us what we do.
Yeah, so from the medical oncology standpoint, we're in charge of treating patients with some form of systemic therapy. That's something that goes into your bloodstream, like either a pill or an intravenous therapy. But to put it kind of in a timeline, fashion, the patient would come in and probably either be referred by the primary care doctor, or maybe by maybe he will see the pulmonologist because he has some type of symptom or something was seen on a scan, and then either Dr. Gotkin or Dr. Block would play a role in diagnosing this patient. Once that sample is obtained, then it would go to pathology where the diagnosis is made, and that tissue would probably be sent off for molecular testing where you would play a role. And then once the diagnosis is made, then the navigator will facilitate getting the patient established to see a medical oncologist or a surgeon or a radiation oncologist, depending. We treat lung cancer. It's a multidisciplinary approach, sometimes radiation, sometimes surgery, sometimes a combination of radiation and chemotherapy, and all of that is determined based on the stage that the patient presents with. From our end, it would be either sometimes systemic therapy prior to a definite procedure, like a surgical procedure. We call that neoadjuvant. It's something that we give before a surgical procedure to try to shrink the tumor, sometimes improve surgical outcomes, sometimes improve survival of the patient. Or other times we give systemic treatment, either with a pill or chemotherapy or immunotherapy after a surgical procedure. We call that adjuvant therapy. Again, something systemic, that's what the medical oncologist is in charge of. And for more advanced stages like stage 4, sometimes it's only treated with systemic therapy. So usually we are mostly treating that stage, in lung cancer treatment. So that's our role in the multidisciplinary team.
Great. And maybe Dr. Gotkin, Mark was talking about diagnosis, but you can talk about, you are the chief of our lung screening program, and the new program that we have nationwide is the IPM. Memorial is the only one of the 3 hospitals in Florida State that has an IPM program led by Dr. Gotkin.
Yeah, so I'm the pulmonologist, and I'm usually the first stop for most patients. So people will come to see me with cough or shortness of breath, which will lead to imaging, which on occasion can lead towards the diagnosis of lung cancer. I also take care of patients who have COPD or who actively smoke or are used to smoke. So in those patients, we make sure that they have what's called screening CAT scans of the chest. So if you're between the ages of 50 and 80 and you have a 20-pack year history of smoking, a pack a day for 20 years, half a pack a day for 40 years, whatever the math is for 20-pack year, and you either actively smoke or have smoked within the past 15 years, we make sure that these patients get annual screening CAT scans of the chest because they're at a higher likelihood of developing lung cancer. So as a pulmonologist, and I have patients who smoke, I make sure that they get their screening CAT scans of the chest. We also have the IPN, or the Incidental Pulmonary Nodule Program, which we are tied in with radiology. So people come to the emergency room all the time. You know, we're a level 1 trauma center. People are getting whole body CAT scans. We have a big cardiology group. People are getting CT cardiac exams. And on these images, they will sometimes include the lungs. It could be the bottom of the lung, it could be the side of the lung, and we find things that we wouldn't typically find. And every Wednesday, we have a meeting with our nurse navigators, our thoracic surgeons, and our pulmonologists, and we review all of these films that have been done in the emergency room or have been done in the outpatient setting, and we look for these lung nodules. And there are certain lung nodules that are more worrisome than others. The size of the lung nodule, the appearance, if they have these little spicules coming off of them. And as a group, we make decisions on the next step in their care. Do we send them straight to surgery? This looks really bad, let's send them straight to surgery. Or this doesn't look so bad, let's get another CAT scan in 3 to 6 months. So what we're hoping to do is to find patients with lung cancer at earlier stages, whether it's through screening or through incidental lung nodules, so that we can intervene at an earlier time, get them scheduled for surgery, get them resected, so that we prolong their survival, improve their likelihood of survival. So that's the Incidental Pulmonary Nodule Program. And we have so many scans that we have to go through. We spend like an hour and a half every Wednesday going through these scans. And then we make sure with our nurse navigators that they have follow-up and that they're notified. Oftentimes people will leave the emergency room, they came with abdominal pain, and their abdominal pain is better, but oh, by the way, there was this lung nodule that they weren't really told about. So what we do is we make sure that they're aware of these lung nodules. We make sure that their primary care physician is aware of these lung nodules, and we make sure that they don't get lost to follow-up. And we keep an eye on them, and we follow them, and make sure that that we diagnose them if they have lung cancer and get them on the right track, whether with thoracic oncology, medical oncology, or radiation oncology.
So, sorry, can somebody turn on my mic? It's really important what I'm about to say. There you go. So pulmonology is, you know, Dr. Raez talked about my mom, Bonnie Dario. She was diagnosed in 2003 with stage 3B non-small cell adenocarcinoma, and this was before all these amazing advancements, and I'm really hoping we get into the amazing advancements across the board as it relates to radiation oncology. Dr. Block talked a little bit about surgery. Dr. Domingo talked a little bit about systemic therapy. When it comes to pulmonology, and we're going to get to pathology because it's also an incredibly important piece, and I think something that we don't talk enough about. So one, pulmonology, we heard Dr. Gotkin talk about screening. And for those of you who are in this room tonight, it's probably not necessarily irrelevant, right? Because you're here because you've already been diagnosed with lung cancer, but here's where it is relevant. and here's where you can be ambassadors for lung cancer screening. I'm an ambassador for lung cancer screening. There are roughly, if you look at USPSTF guidelines, which are the people who make the guidelines for screening, there's roughly 12 million people in this country that qualify for screening. If you tack on top of that ACS recommendations, American Cancer Society recommendations to remove the 15-year quit history, it takes it to about 16 million. When you look at averages around this country, of those 16 million people who are activating around lung cancer screening, it's between, some people tell me it's up in the 20 percentile. I disagree with that. And in pockets around the country, the average is more between 7 and 12%. We all know that cancers, not just lung cancer, but cancers diagnosed early, the people have better odds of cure. So all of the people who are living with lung cancer can be ambassadors for this. We all know someone. whether it's our neighbor, our mailman, our clerks at the grocery store, right? The people checking us out, to just be talking about lung cancer screening and spreading the word, because I feel like it's so important. So that work is incredible that is happening out of MCI. And second to that, pulmonology, when someone is diagnosed with lung cancer, their pulmonary function is compromised, period, hard stop. I don't care whether it's because of a comorbidity, because of, like you said, COPD or emphysema, something like that. But even if it's not that, if you've had a lobectomy or some sort of thoracic surgery, right, your pulmonary function, or radiation oncology, like your pulmonary function is compromised. So having someone on your care team whose specialty is the lungs is of the utmost importance, so that they can monitor not only your pulmonary function, but how your breathing reacts at altitudes. And that's not just, oh, I'm thinking about climbing Mount Everest because it's on my bucket list, but I'm thinking about flying from here to California at 37,000 feet, where the cabin is pressurized at 8,000 feet. So this is something that I just wanted to bring attention to.
Right, so we see patients preoperatively, we see patients postoperatively, we help get them ready for surgery, we help determine if they're even surgical. So in addition to our Wednesday afternoon incidental lung nodule meeting, every Monday morning we have a multidisciplinary tumor board where we discuss cases with medical oncology, thoracic oncology, radiation oncology, we have radiologists, and we review films, and we talk about what we should do for these patients. So we all work together. We all make sure that the patient's getting the therapy that they need, and that it doesn't make them worse off than they would be otherwise. So, you know, as a pulmonologist, we treat with oxygen, we treat with inhalers, we see them in the preoperative standpoint, we order pulmonary function tests, determine their ability to undergo surgery, and if not surgery, radiation. And we see them postoperatively because, like you said, their lung function can decline after surgery. They have pain, they're just not breathing well, they're wheezing a little bit more. So we're with them throughout their whole course. And we work hand in hand with everybody up here throughout that course.
Yeah, maybe to add on that, a lot of you now are lung cancer survivors, so you come every year, you know, for your CAT scan. So we are sure that you are still clean and you are cured. The lung cancer screening is very important because not only what they are saying about the lack of awareness, even if, for example, we convince them to come for one time, when the results are negative, there is no cancer, they don't come back in the future. So that's why. I love the fact that, you know, when you do a mammogram, you don't do a mammogram once in your lifetime. You do a mammogram every year. So that's why it's very important that you help us to spread the word. We need to do these lung cancer screenings every year. We are so lucky now that it's paid by insurance, so you don't even have to pay out of the pocket. If you don't have an insurance, every cancer center in Florida, you know, will give you for $100, $120 out of pocket, so it can be done. The second thing I want to say is that this is the lung cancer screening. The incidental nodule program, I don't know if you catch what Dr. Gotkin was saying, is this is nodules, lung nodules that we find when you have something else, especially when you come, for example, from a car accident and you think that you have a broken rib, you get a CAT scan and you don't have a broken rib. And so you are so happy, they said, hey, you don't have a broken rib, so you run home happy. And they said, hey, but by the way, you have a nodule that you need to tell your primary care to check in 1 year. That last statement, you know, tell your primary care to check in 1 year, you are so happy that you forget about that, you know. So 1 year later, you don't remember, and your primary care doesn't remember. Nobody remembers. Now you have a nodule that may be cancerous that is growing. 3 or 4 years later, the cancer may be spread, and it's too late. So that's why I'm very proud to work for Memorial, because we convince our leadership to invest resources to create this program. And tell you, this program is not easy. That's why we only have like 3 in the whole state, and we have 85 cancer centers in the state. So basically what we do is, we bought an AI. Everybody likes to talk about AI, so you want to put it, yeah? So, because Memorial Healthcare System does 250 CAT scans per year. So how many navigators we can, 250,000 CAT scans per year. So how many navigators you can hire to go and check one by one 250 CAT scans? That's impossible. So that's why, thanks to AI now, we have an AI solution called Illuminate that will review the results of the 250 CAT scans, and they call awareness of, hey, there is 5,000 that they need to be reviewed. Even that 5,000 is a lot. That's why I praise our IPN team in the back. You know, thank you, ladies, for coming, Andrea and the team, because they review the 5,000. You know, I wish we have a better AI that can tell you, hey, you only have to review 500. You know, but our AI has limitations, so we still have to review 5,000 cases and see, and then our team chooses the cases. So Dr. Gotkin, Dr. Block, and their teams review every week. So it's a lot of work, but it's a lot of work that makes us very proud, because then we find, I don't remember, in the last 3 years, we have found around 120, 130 lung cancer cases that would have been missed. No, 130 lung cancer that were missed. So that's why we do this. You know, we're very proud to invest resources doing that to save our patients, because as Dr. Gotkin said, if we catch these cases stage 1, stage 2 with the surgery, we can cure them. You know, so it's much easier to cure them than to be stage 4. So that's why we're very proud to be doing this, and we're going to be doing this, and hopefully we'll find a better AI, better resources, so we can save more people. But now we have, everybody's waiting for the Paul Hakimata. You know, he has a very important role, because we need now, in the past when I studied medicine, there was only 2 types of lung cancer, no? Small cell and non-small cell. Now I don't know how many we have, but so his job is to classify them.
Right. So where I come in is directly after Dr. Block. So when Dr. Block does, and his team does a procedure to take out a specimen from a nodule, right? Because at that moment, they don't know 100% sure if it's cancerous or not, right? It could be a cyst. And simply because our lungs, you know, we breathe in air, there's all kind of things that come in and we breathe it out, and we hope everything that we breathe in comes out again, right? So they send that to the lab, and then we check physically if that's cancerous or not. And if it's cancerous, we make a diagnosis of what type of cancer it is. There's a variety of tests that can tell you if it's indeed lung cancer, or maybe if it's a colon cancer that was metastasized to the lung, right? So, because even if we see a lung nodule and we detect that it's actually colon cancer, we need to search where that main tumor is. Maybe we missed something. Okay, so that's one side of it. Now, if we do see lung cancer or any other type of cancer, then we follow with a genetic test after that. And the genetic test, what it does, it looks at your DNA and your whole genetic makeup, and we try to find these mutations, maybe what could cause that cancer. Or is there a mutation that you have that we can match it with a drug? And then this all goes into a report that's pretty extensive, and it goes back in the medical record, and then the physicians then will make a choice if they're going to target that particular mutation with that drug that we recommend, or there's a different drug out there, or maybe there's a dosage that they need to adjust. So that's how we fit in this whole spectrum.
Hi, me again. So this testing and pathology is incredibly important to people diagnosed with lung cancer, personalizing what their lung, and no 2 lung cancers are the same, right? Dr. Raez just said, we still don't know how many different types there are. When my mom was diagnosed, there were 2. And it was like throwing pasta at the wall. Let's see what sticks, right? It stuck with her, thank God. But we're here to talk about some of the challenges with multidisciplinary care, and even when I think about pathology, you talked about DNA testing, and I mean, we've come a long way with biomarker testing, just to kind of bucket it that way, right? But now part of the challenge, particularly in smaller community rural settings, is which test do I do? Is DNA, RNA, IHC? Like, so this is can you talk about that just for a minute?
Yes. So at this moment in time, and as you guys know, the technology is moving at lightning speed, right? It's no one almost can keep up. What we see is that from a surgical perspective, the procedures become smaller and smaller, simply because you heal faster. That also means that the specimen becomes smaller, right? That means for less specimen, we want to do more and more and more tests, which doesn't work exactly like that. Now, there's a whole variety of drugs out there that you need to have, let's say, proteins expressed, which is these markers that are on the outside of the cell, right, of your cancer. which are different from the DNA that's inside your cell. The RNA is also something similar to DNA, but it can detect a few other type of variations, if you will. So for all these variants that you can detect, there are drugs available, or not for all, but for some, right? So we try to detect all of these. Now, within any type of cancer, there are certain mutations or certain variants that are more often present, so there's a higher chance of catching it. So as these samples become more and more scarce, someone needs to make that decision, right? Okay, we want to do either 10 different tests, but on this particular specimen, we can only do 5. Which 5 are we going to do? Right? So now the goal for us is to stratify, like, okay, if we can only do 5 tests, let's see how we can have the highest chance of catching something to help the patient, right? And also do the most possible with that specimen, okay? Now, when we do it inside Memorial, what we have as an opportunity is we can maybe combine this with different specimens from that same patient, right? Just to bring up the amount of DNA. So with doing that, even though that mutation that we're looking at is a less fraction of it, we're able to find it. Whereas if we only had the DNA from the tumor itself, it might not be enough to even run the test. Right? So there's ways of rescuing. And these are things that at Memorial we're trying to do to in the end help you guys and get to a result faster.
Great. Great. Okay, so it's too much talk from us now. So we want to hear the patient. So please, you identify yourself and then ask your question or comment.
Hi, my name is Michelle, and Dr. Raez and Paula and Ariana are my angels. So my question is, I had stage 4 lung cancer, and because of Dr. Raez, I had the biomarkers which matched. But I remember when she was just talking about, I took a test with my doctor like 12 years ago because I was a smoker, and she was told against smoking, so she had me take a test because she told me I might have cancer in 10 years. Or she said I would probably have COPD, and I ended up getting lung cancer. But because of the biomarkers, I haven't had to have chemo or radiation, and I've just had the pill, and I've been on remission for 2 years. So my question is this: I still get a CAT scan every 8 weeks, Dr. Raez. So how long do I have to keep getting a CAT scan? I mean, although it's like a safety net for me, it makes me feel good to know that I'm getting it 8 weeks, but how long do I have to take that? And the medicine too. The medicine I take has been great for me, and I'm really, really grateful. But I'm at the process where sometimes I'm always like nervous that it's getting ready to come back because I've been doing so well. But how long, where do I go from here in my process? Do I still go to the thoracic surgeon? Because I haven't seen a thoracic surgeon since I've had the thoracic surgery. So when I, going forward, what do I do to keep myself up to date, healthy, and doing the right thing?
No, the treatment is, we don't know. So these pills, some of them are very successful, like the osimertinib, the Tagrisso for EGFR, and ALK and other genetic aberrations. But we don't know how many years you have to take to be cured. So that's the important question. In breast cancer, sometimes you take pills for 5 years, sometimes you take pills for 10 years because we have the information. In lung cancer, we don't have it. And we still have to be doing your scans. And now remember, some of you, we also have tumor monitoring in the blood because now we have the technology in Memorial, because there is a chance that the pill may fail you one day. So that's why until the day that we can know that you're cured, we have to keep doing the scans, the blood monitoring, and you have to take the pills. The good thing is most of these pills that you take, we have more than 15 pills, they are very safe. There is not too many side effects. There is no chemo. So that's why you can take the pills like you take your blood pressure pill, your diabetes pill. So our goal, one of our first goals until we can cure this disease is to make it chronic. So you take your blood pressure pill for your whole life and you don't worry about that. So hopefully until we cure the lung cancer, we can do the same.
So with the pill, sometimes when you stay on the pill so long, it's not as effective. Is that a pill like that too? Like if you stay on it for 5 or 6 years, it doesn't give you the same results?
No, that's what I'm saying. We don't know yet.
don't know that.
Hopefully one day we'll know. And for sure, you know, some of you are taking the pills for 6, 7, 8, 9 years. We believe, we suspect that you are cured, but we don't know that yet, you know? What do you think?
Yeah, we're always afraid of stopping the medication and the cancer coming back. So usually we treat, we say, until unacceptable toxicity or disease progression, meaning you're having a side effect where you can't tolerate the pill, or the cancer came back, means the cells develop some form of mutation, way of escaping that blockade that the pill was providing, and it keeps growing despite the pill. And then at that time, you know, usually we detect that either on a scan, we see some form of like tumor getting bigger, or a new lesion somewhere else, or we detect the blood levels coming up. And at that time, then we have to, usually what we do is we'll test again. We'll try to get a sample from whatever we see findings on the imaging, and we'll take also a blood sample to test the molecular, do the molecular testing again, and see if there's another mechanism that we can block with a different pill, or something else that it can help us guide the next line of treatment. But until that, usually we stay, you know, keep patients on the same medication as long as it's working, and the patient's tolerating it well, and the cancer is under control. We keep the patients on treatment.
Believe me, I'm not complaining.
And then one comment. From the radiation standpoint, one area where we've seen a big change, kind of like in the type of patient that we're treating, is that these newer treatments, patients are doing better. They have relatively minimal side effects, are responding well. And there are situations or instances where the pills control the cancer for a very extended period of time, but there may be just an isolated tumor or nodule that's growing and that's maybe become resistant to the pill. So there are instances where if a patient has what's called oligoprogression of the disease, we can consider doing very focused radiation or surgery or some sort of ablative treatment just to that one nodule and still keep the patient on that same medication without having to switch either the pill or going on to chemo or some other systemic treatment.
Great. Another comment or question?
Well, I'll take the chance, since you did mention thoracic surgeons, I'll take the chance.
You want to talk?
No, you asked a question that we get a lot, which is how often do you need to see the surgeon? Historically, most patients with early stage lung cancer, stage 1, would have surgery and never get additional therapy. And so the surgeon was the primary means for follow-up. So we would see patients a few times in the first year, and then every 6 months or every year thereafter. Now, though, that so many more patients are getting combined modality therapy, after surgery, they'll wind up seeing Dr. Raez or Dr. Domingo or Dr. Castellon and getting treatment and follow-up scans with them. So typically after a year, I'll tell the patient, you don't have to come back and see me, you're already seeing somebody else. It's just duplication of effort. But I think as a surgeon, it is important to see the patient, at least for the first year, to make sure that they haven't developed any surgically related complications.
Great. We have somebody else, Daniel?
Yes, my name is Heidi Onda, and I'm surviving almost 7.5 years. I just want to thank you for presenting today so people can really understand that there is a team involved in putting your care together. And what I find is evolving now, being almost 8 years out, that we weren't expected to live this long. And so our multidisciplinary teams need to be expanded for our care as we go through treatment for 8, 10, 18 years here. I ended up having a non-STEMI heart attack 6 years after my chemoradiation, and it looks like, you'll see my map later, had to do with long-term effects of radiation, but no one was following me. I had never had a cardiologist put on my team, and I just think we need to be talking about long-term effects of whether it be radiation, systemic treatments, targeted treatments, because thanks to you, we're living longer, and we want to keep going. And help us spread the word to our primary cares, our cardiologists, others that really need to be in the loop.
Amen. No, that's a very important comment, Heidi. Thank you.
One comment on that. So I think in the radiation community, there's been greater effort as far as understanding kind of the importance of minimizing the amount of radiation to the heart when we treat lung cancer. So I think there's always been, over the course of the years, there's been greater effort in terms of improving and refining the radiation techniques to minimize dose to the heart. And in addition to that, there's now even a field in cardiology of cardio-oncology. So we work closely with one of our cardiologists in Memorial who primarily sees cancer patients who have cardiac-associated side effects, not just from radiation, but also other kind of oncologic treatments that could cause cardiac toxicity.
Now, this is very important because cancer survival maybe 30 years ago was short, so we didn't have a chance to see side effects from treatment because you didn't survive the cancer. Now, really, we have, in America, we have, if I remember, 20 million survivors in America, 20 million cancer survivors, and then we have to see long-term side effects from the chemo and the radiation and the other procedures. So one thing that we do at Memorial that we can do for all of you is we are doing survivorship plans. Yeah? That means that, if you were treated for cancer in 2005, maybe you don't even remember the name of the chemo, you know? The survivorship plan is like a couple of pages that said you got treatment that year, 2005, you have these chemos. The doses of the chemo matter because if you get cancer again or you have another problem again, that doses of the chemo may affect your current treatment. And the same with the radiation, as Dr. Castellon said, you know, in the survivorship plan, we said you got this chemo, you got this radiation dose, so if something happens in the future, your new doctor or the new place. So that's why this is called survivorship plans. We are very engaged doing that. If you're a survivor and you don't have a plan, the next time that you come to visit, our APPs will do one for you. But that's very important because you can carry in one page or take a picture. So in the future, you know, when nobody remembers anything, you can say, this is my record. And that's very important. You have another one, Daniel?
Somebody else?
Oh, we have here.
Hi, Ignacio over here. 10 years ago.
Okay.
10 years ago.
Oh, yes.
Yeah. 1 in 20.
One in
4. Cancer. You don't mind me talking, honey, do you?
Yeah, it was 10 years ago.
10 years ago. I'm still a wife, not a widow.
He's cured, he's cured, he's cured.
And Dr. Raez says, I have, with the machine you show us with the alarm, with the red light and all that, you says to me and my daughter and my husband, the bad news is that your husband has a cancer in the lung. The good news is the 3 things you tell us: family support, you have good insurance, and have hope that you're going to survive. But the next thing you told us was that there was 1 chance in 20, and one chance of survival in 20, in 20 patients. So today you says that it's even better. What is the chance today?
Yeah, now it's 1 on 4 probably.
1 in 4.
Yeah, 1 on 4. Yeah.
And I do have a lot to say about Memorial, not Dr. Raez and Dr. Castellon. The same very month that my husband was diagnosed with this ugly illness, my friend, like a sister to me, came with a breast cancer. Dr. Castellon. She has nothing. She survived also cancer.
Great.
Thank you to you all.
Thank you. Daniel, in the corner. Yeah, this is a very good thing because when most of us start to do lung cancer, unfortunately, the survival was only 5%, so 1 in 20. But you know, your husband was the first one, I think, in Memorial that had immunotherapy. You know, we have immunotherapy as a research, and he got the first. He was, I think, the first patient or the second patient that got immunotherapy Memorial, and now you know immunotherapy is approved for 40 cancers. You know, it's a very important treatment. Unfortunately, as I said, it only cures 25%, but we jumped from 5 to 25. You know, so that was a major jump, and thousands of lives saved thanks to immunotherapy. You know, so yes. Or we'll hear first.
Hi, good evening. My name is Laurel, and I'm a guest of my friend here who had some really good results. I don't know anything about lung cancer except through her. And I just wanted to know what the symptoms were, because you mentioned that somebody had an accident and a CAT scan or something which showed something on the lung, and it could be lung cancer. So what are the symptoms that we would look for somebody who doesn't know anything about lung cancer?
So unfortunately, there are no real symptoms until it's too late. So that's why we have screening to find things early. You could put yourself at more of a risk of developing lung cancer by smoking. And that's why we do screening for those high-risk individuals. But unfortunately, the symptoms don't usually come till it's too late, till it's spread. I mean, you can start coughing up blood, you can have chest pain, you can have shortness of breath, but really, there's no symptom per se for lung cancer. So that's why we do the screening in those high-risk individuals. And even now with the screening, we're still trying to understand who to screen. At one point, we started at age 55. We've lowered it down to 50. But I'm seeing, and I'm sure everybody else here is seeing, a lot younger patients than we've ever seen before, and people who've never smoked also. So we don't really know yet what the right group to screen is, and we can only go by what's been studied and what's published. So for now, it's 50 to 80. And screening means you're doing this in somebody who's asymptomatic. All right, so they don't have symptoms, because then it's not screening anymore. So unfortunately, there are no real signs for early lung cancer, only signs for late stage lung cancer, which is why we recommend early screening.
So you would, like a mammogram, for instance, for breast cancer, you would recommend screening from like what age?
So right now the guidelines are for starting at age 50.
And that would be for people who may be at high risk.
At high risk, meaning that they've
smoked all their lives.
What's called a 20-pack year history. So if you take the number of packs per day that they smoke, and times it by how many years they've smoked, if it's 20 or more, those are the people who are at higher risk and who are eligible for screening. So age 50, active smokers, or people who have quit within the past 15 years and have smoked the equivalent of a 20-pack year history.
So if someone has another type of cancer, or you think it would be like generic, passed down?
So again, these are we're sort of at the beginning of screening, and right now we're missing so many people, right? So what, 5 to 10% of eligible patients who are eligible to be screened are getting screened. So right now we have this group, and we're not doing a great job at getting these people screened, so we're trying to get the word out to be screened. However, there's a whole nother group of patients that we just don't know, whether it's something genetic, environmental, we just don't know. I don't know, there are some blood tests, I guess, that are out there now that I don't know if Dr. Raez wants to talk about, but...
Yeah, we in Memorial we do research, and because these long nodules are not 100% accurate, meaning when Dr. Gotkin, remember I give you the example, we have 250,000 CAT scans. The AI said, oh, there is 5,000 suspicious nodules. But at the end of the day, we only diagnose 170 lung cancers. So a lot of these lung nodules are benign. And it's a nightmare because our navigator had to spend hours and with the surgeons and pulmonologists reviewing. So now what we're trying to do is to find cancer in the blood. We want to try to find cancer in the blood. There is no one company that has found the Holy Grail yet, but a lot of them are very close. So we work with one of them, so that's why when we do research with one of them, that when we find a lung nodule, we do a blood test, and we are trying to see if the blood test can predict that this is cancer or no. Because what we find in the blood test is some cancer cells that have been shed, detached from the tumor, so we can catch them in the blood, so we know that the lung nodule is malignant. So we're close, but we're not there yet.
And even separate from the lung nodules, there are screening blood tests that may not be available through insurances like Valerie or things that.
We just passed a bill earlier this year, the MSET bill, multi-cancer early detection test, and coming to all of us in January 2028, Medicare is going to cover.
Yeah, that's a very nice story. You know, in politics today in our country, nobody agrees with anything. Yeah, if one side of the aisle says yes, the other side say no, and this side say no, the other say yes. So this is one of the first things that everybody agree. So basically, the bill is sponsored by a Republican and a Democrat together, that we want to have Medicare paying for these cancer tests. So we do a blood draw, and we will tell you if you have one of the 70 types of cancer. Because if you think about, we are only screening for 4 cancers, and there is more than 100. So doing your mammogram and colonoscopy, you are protected against 4 cancers. How about the other 69, 70? So this blood test is trying to catch the other 70 cancers. And we are lucky that our politicians got agreement, so Medicare will pay for the screening. The problem that we have is that the test is not very good. Yeah, but I guess for the politicians, for both eyes, look good to approve it. So anyway, it's better than nothing. Yeah, so we'll still have to wait 2 years, but it's not bad to wait 2 years, because hopefully in the next 2 years, we can develop a better version of the test so it's more accurate. Because what we don't know is that you go to your primary care, you get a blood test and say, oh, you have cancer, and it's not true. And all the stress that you go, all the tests and scans, so that's the disadvantage of the test now. They are not accurate enough yet. Hopefully it will be soon. And well, if the government is going to pay, but better for us, you know. So we have, usually we consider a high risk for cancer individuals more than 50-year-old, because usually the younger ones, very few get cancer. So we have, yes.
Hi, my name is Maria Wertheim. I got diagnóstico de cáncer.
She got diagnosed of cancer in
2024. And yo fui para algo diferente.
And I went to the doctor for something different.
Tenía fiebre.
I had a fever. I wasn't feeling well.
Y fui a emergencia en
And I went to emergency
in the Memorial.
Memorial Hospital Regional.
Yeah, and then me dijeron que tenía muchas infecciones.
And they diagnosed it with a lot of infections.
So when they had all these results and all these tests, the doctors say, you're not going home. I don't like when I see in the lump. I never got sick. I'm 65. My mother is 95. I never got COVID. And then they told me I had to get a biopsy.
They told her that she needed a biopsy.
So I spent like 7 days in the memorial, which I belong for 4 years, and also I belong to the Cancer Association donation for, before all this, I always donated for 37 years with my company, always. And my license plate and my cars, somehow, always with the lung cancer. It's so many things together. So, and then I left the hospital and they told me, no, you have to go see your primary
doctor.
Catherine Mendez Martinez. I went there and she said, no, I had to talk to you, but she was my doctor, she's my doctor for 11 years and she knows how healthy I am. I don't smoke. I never party, I never do drugs, nothing. Not even sick in 65 years. And I'm here in America from 40 from Colombia. So she said, no, you know what? I'm gonna recommend you can go see Dr. Luis Eduardo Raez. That's it. She said, don't worry about it. We don't have time to cry We don't have time to anything, and you can go see Dr. Francisco Thoracic. And then he told me, don't worry, everything is fine, boom, boom, boom here. And he said the surgery is in a couple of days. You're lucky, everything on time. And I got they have the robotic surgery. I was lucky. I just want to thank the memorial, Dr. Raez, Paola, Dr. Paola Izquierda, everybody. It's like in my family. Even I don't have to go too often anymore, I show up. I show up with the coffee, I show up with the empanadas. I have to see this. My husband say, I think you like the doctor because you always want to be there. See, I love the memorial. I love the person that helped me from the front desk. Everything, beautiful. Really, I really appreciate it. Thank you.
Anybody else? Stage 4? Stage 2? So you I don't know your story.
I'm sorry, I don't like to talk like this. I'm an 18-year survivor as of last week, and I've had lung cancer 2 times. Thank you. I've had lung cancer 2 times. I was first stage 2, second time stage 4. And thanks to Dr. Blocks, who's done my surgery twice, and Dr. Raez, who's been just the best. And Paola, of course. It was wonderful. I appreciate all of you.
Anybody else? Yeah.
Mi nombre es María Sea.
My name is Maria Cia.
Soy paciente de hace 40 años que me dio por primera vez el cáncer. Luego me cortaron el primer tumor, me cortaron el seno, luego el segundo. Hable usted.
Okay, my name is Liliana Velasquez. She's my mother. She's 80 years old. She was diagnosed 40 years ago in Los Angeles of breast cancer. She has nuclear medicine, I'm sorry. She was on radiation. Then we come back here to Miami on 1990, I'm sorry. After 4 years, she was diagnosed and another breast. So it was on 2006. Now she been through for 6 types of cancer. The last one, she had twice cancer on her lung. The first lung cancer was 10 years ago. She has colon cancer. She never smoked. Lung cancer, both breasts, skin cancer, and 10 years ago when she was diagnosed for lung cancer, Dr. Thoracic was attending her and Dr. Ferraro. They cut half of the lung. Last year, she started to coughing. She was attended by the pulmonology, Dr. Jorge Barros. He's a very good doctor, too. So he sent us to Dr. Luis Raez, thank God. And she started to coughing and get some splits on blood. So what I tell you, anyone here, you need to listen to your body. Your body told to you. I was diagnosed 3 years ago with breast cancer, and my sister at the same time. So everything came together. For my mom was very hard. So after the thunderstorm, the calm is coming. The only thing, after all these years, because my mother is my mirror, she's a very amazing person. She's very strong, and she's always positive. Everything is here in your mind, faith in God, and the doctors. We are in good hands. Everyone is exactly like another lady say. We thank every single day to the hospital, everyone, from the people from the parking lot, the enters, the reception, we love everyone. Thank you so much for everything you've done.
I'm a little nervous here. I just want to say, Dr. Raez is a gift from God. I am a patient of his, and I saw him on Monday, and it was the 3rd CAT scan, and he said, I'm fine. So I was first with Dr. Thoracic, and I failed the breathing test, and he didn't operate, he couldn't. And he sent me to Dr. Raez, and that's why I'm alive today. And I'm 84 years old. But he told me I could have 5 or 10 more years. Thank you, Dr. Raez.
Yeah, we have a 96-year-old here, so we have a... Yeah.
Hello to the... Can you hear me? Hello to the panel. I want to thank Dr. Raez. Where is my girl over there? Oh. And the whole panel for Cancer Center. Because when I got diagnosed, they told me I might only have a year to live. Yeah. But thank you. In a month and a half, I'll be 70 years old.
Yeah.
So thank you so much, because I'm feeling well. I'm walking 2 miles a day, going to the gym, and being very active with my grandchildren. So, you know, I'm hoping in another 2 years to see a couple of my grandkids graduate college and, you know, keep healthy and strong. Thank you guys.
Hello, my name is Shirley. I have a question for the panel. Now that we have vaping that's going on and these young kids are doing it more than ever, have you seen any patients coming up with that now, or even with the hookah that's more prominent with the young patient?
Sure, I'll take that. I'm presuming you're asking about vaping. That's a very big topic, and there's a number of, I think, important developments for all of us to understand. Vaping is really breathing in an aerosol, and for most kids that means breathing in nicotine and becoming addicted to nicotine. The aerosols themselves are probably less toxic than cigarette smoke in the long run, but they do have toxins in them that can affect lung function acutely. You may have heard many years ago there were a number of kids who wound up very sick in the hospital, and some of them died. That was from an additive that has since been removed from those products, so fortunately we don't see that anymore. But there are acute lung injuries from vaping. I think the take-home message, there are two important messages though. First is that vaping is really a tool for becoming addicted to nicotine, and I think everyone in the room here who has been addicted to nicotine knows how horrible an addiction that is. It's the most difficult addiction to quit. It's very hard to do. And so once kids become addicted to nicotine, then that opens the door not only to a lifetime of nicotine use, but also to cigarette smoking. So there's been a lot of work to try and reduce vaping amongst youth, and the good news is that it seems to be working. The bad news is that we are now seeing the emergence of two other trends. One of them is called ZYN is the trade name. I don't know if you've heard about that, but those are nicotine patches that kids now can put on their mouth. It's the synthetic nicotine, so it's basically pure nicotine. And it is addictive, and it is becoming a real problem that kids and people, adults, anyone, can use them and you don't know it. It's not like a cigarette or a vape where you have to actually use it. You put it in your gum and you don't know anyone is using it. And it's becoming extremely popular, and it's very addictive, and we're seeing oral health problems as a result of that. The other trend that people should know about is that cigarette smoking is becoming cool again. Not only do we see a lot of celebrities doing it, it is being promoted more and more in entertainment, movies, Netflix series. We're seeing cigarette smoking more and more common, and we're actually now seeing influencers promoting cigarette smoking. So that's a trend that we're watching pretty closely as well. So yeah, hookahs are actually significantly more dangerous than cigarettes. A night in a hookah bar is equivalent to smoking about 3 packs of cigarettes. But fortunately, hookah use has gone down amongst the youth. I mean, you still see hookah bars, but it's not as popular as it used to be. So all of those are important considerations for public health. I happen to work with the American Lung Association pretty closely on advocating for these issues. But I'm glad you brought them up.
Yeah, I also want to add also, for example, the smoking with marijuana. In our times when we were kids or with our parents or uncles used to smoke, it's not the same that we smoke now. So that's why our senior people say, oh, marijuana is not a big deal. I used to smoke marijuana in college, no? Because the marijuana had a fixed concentration. You know, if you do the plant, it's a fixed concentration. I don't remember, it's 10% or something of THC. Nowadays, thanks to the vaping, you can put as much as you want. So a true story, for example, is that one day one of our nurses at work was called from the high school because his son had a cardiac arrest in the bathroom. And they were with other kids doing the vaping in the bathroom. And we didn't know what happened. He was intubated, actually, spent 3 days in the ventilator, and thanks God he was safe. But they discovered that the vape has 70% of THC. So that's like 7 times the doses that your grandpa used to smoke. So that's the problem. The cannabis that we smoke today is not the one that they used to smoke now, because in the vaping, you can put as much as you want. It's to say, if you don't buy the legal one and you buy the counterfeit, you don't know what they're putting there for you. And now we have the fentanyl too. Fentanyl is only some drops that you have to put, or some, and you can kill a person. So that's why, for all of these dangers, I think it's better to educate and take away the sensation or the feeling, oh, cannabis is not a big deal, vaping is not a big deal. No, these things can be a big deal or can help you escalate to other products that are more dangerous, no? So that's why there is no medical society that endorses, for example, the use of vaping or the use of cannabis, for example.
So, yeah, I'd like to add on to that. Remind me a couple things I forgot to mention. There has been a lot of interest and a lot of press on using vaping and other mechanisms to quit smoking, help smoking cessation. A lot of advocates will talk about data to support that. The data is not very clear. There are some studies that suggest that vaping helps people get off of cigarettes. The problem is that now they stay on vaping forever. It has not been demonstrated to be an effective smoking cessation tool. So the data just don't really support it. But the other thing that I forgot to mention is that I think when it comes to understanding the health hazards of something like vaping, it's really essential for us to keep things in perspective. And what I mean is that cigarette smoking used to be thought of as a healthful thing to do, right? We gave out cigarettes to all the soldiers. In the 40s and 50s, you could see advertisements for Camel cigarettes. My physician recommends Camels are the smoothest. So human beings were smoking cigarettes for 40 or 50 years before we realized that they actually cause cancer. Before the Surgeon General came out with that report, it was many, many decades of cigarette use. So I think to believe that after maybe 10 years of vaping, we now know it's safe is, I think, very naive. And I'm worried that 20, 30, 40 years from now, we're going to see an epidemic of people, maybe not with lung cancer, but with serious lung-related problems, all traced back to vaping.
Okay. Daniel, we go back to you now.
Yeah, thank you. So we have one more special presentation tonight, the White Ribbon Project. So some of you might be familiar with, but if you're not, you're about to hear about it. These white ribbons on your tables. And so sorry, it took me a second to pick that up off the table. There's plenty more back here, and I would invite, I'd like to invite Heidi and Pierre Onda to come up and talk to you a little bit about this campaign, trying to help eliminate stigma and raise awareness about lung cancer and the fact that anyone can get it. And here they come, Heidi and Pierre.
The mic.
Well, again, it's an honor to be here. Once again, I don't know if most of you know, but when Heidi was diagnosed with lung cancer about 8 years ago, it was one of the GO2 living room podcasts that introduced me the first time to the lung cancer community. So I want to thank everybody for that. But again, for those of you who don't know us and the White Ribbon Project, the White Ribbon Project is a grassroots, all volunteer lung cancer advocacy organizations whose primary mission is to promote lung cancer awareness and connect people to organizations like the GO2 foundations and promote, I think, best practices and things like multidisciplinary boards. So I'm gonna let Heidi talk for the next 15 minutes about how to all become ambassadors, lung cancer awareness ambassadors.
So we are a nonprofit 501c3, and our mission is to increase lung cancer awareness by changing the public perception of the disease. Anyone with lungs can get lung cancer. We've learned that tonight. I learned that the day I was diagnosed, and no one ever deserves it, ever. So this is us and our family. And being a lifelong health enthusiast, health educator, and a fitness trainer, married to a primary care physician, my family and I were just blindsided by my stage 3A inoperable lung cancer diagnosis in October of 2018. I didn't have any detectable biomarkers, and I was inoperable, and I was basically told there was no hope, 4 to 6 months, sorry, too bad for you. That's how it felt. And here I am today because research matters. I was able to get chemo radiation, so I had cisplatin and 30 radiation IMRT to my mediastinum and my tumor. There's my map up there. And a new immunotherapy had been just FDA approved a few months before my diagnosis, and I was able to get something called durvalumab. Those were immunotherapy infusions every other week for a year, 26 infusions. My last infusion was January of 2020. I have had no cancer treatments since, and I have been no evidence of cancer since. I won't say no evidence of disease because I did end up having this heart attack out of nowhere. And I want to make it extremely clear that I have no regrets about my treatments. I would sign up for that radiation again in a heartbeat because that's why I'm here today. I just wish I would have had the same follow-up care that people with other cancers who get the same type of radiation that I had 66 grays, would have had a cardiologist put on my team early on to be following me. So how did this very shy, introverted woman want to tell her story to the world? Well, I was very private about this, and I was also very embarrassed about this disease initially because I didn't know anything about it, and I thought, I've always been proactive in my health. How did I end up with lung cancer? And was just pretty quiet, living my life. But as I learned more, I became outraged that I didn't know it was the #1 cancer killer. I didn't know that anyone with lungs could get it. I didn't know it was the #1 cancer killer of women. And how were people gonna know that around the world if we all stayed quiet? And looking at all the awareness that was going on at my cancer center, every color under the sun for awareness, you know, green for liver cancer, pink for breast, blue for colon, even the 4th of July, and never anything for white, for lung cancer, which is white. And I snapped one day, and I asked my husband to make me a big white ribbon out of wood that I could throw on my front door, which is red and it stands out, that I could at least teach my neighborhood that I had lung cancer, I wasn't ashamed of it, and we all need to talk about it. One picture on social media went viral, and before we knew it, we were sending ribbons at no cost, at our expense, to people all over the country, patients, caregivers, doctors, clinicians, you know, scientists, anybody, industry partners, and we were happy to do it. With industry help, we were able to get these ribbons to initially 36 countries. Now we're in over 46 countries with active advocacy. And we were global just within 3 months of that first ribbon being built. So here's what we like to see. You might be thinking to yourself, what can I do? What do I do with this ribbon? I mean, it's big, right? The first one that was 24 inches tall, 1 foot wide, has been the only size we made up until last year. And then we started to make this more portable size that's 18 inches tall. They're all on your table. You're welcome to have them. There's more in the back. Please take them. They're free. Is to get people talking about this disease. We do PSAs on airplanes sometimes about lung cancer screening when they see these ribbons. But the main goal was initially to get these ribbons in waiting rooms, because I remember sitting in radiation oncology every single day, and in November, that's when my treatment started, surrounded by pink. Everything was pink. And I didn't even know it was Lung Cancer Awareness Month. But if we could get these in a cancer center, people would at least identify with it. They would know that, you know, somebody's thinking about this disease. It's not just me. And this is our one-pager. It explains what we are. And the QR code takes people to the website, which then helps people connect to organizations like GO2, all the advocacy organizations around the country, where people can get connected and meet other patients.
Yeah, we also like to support any organizations that want to improve healthcare for people who may be at risk for lung cancer. In this case, it was a group of community healthcare clinics in rural southeast Kansas, and they wanted to promote their lung cancer screening program, and we wrote a grant to help support some promotion for their call center, as well as upgrade their IT systems to help them identify their eligible patients, and also provide some CME for their physicians. Another grant, there was another group, the Southeastern American Indian Cancer Health Equity Partnership. They wanted to educate their youths about both the sort of history of the cultural significance of tobacco use in their community, but also the adverse effects. And so hoping to teach their youths about it, and also hoping that they would outreach their relatives who may be eligible for lung cancer screening.
So what could you do with this ribbon? You're looking at it. You could put it on your front door like I did. You could put it in your window. You could keep it in your house. Just something to start a conversation. And those conversations have really evolved, and awareness is growing. You could host a ribbon painting party. Look at our friends at GO2. We make this super easy. If you want to do something in your neighborhood or family or friends, we'll send you ribbons that are ready to paint, and we'll send you the labels, and you can have some fun with this and help spread awareness. And then when we get requests for ribbons from the website, we could say, oh my gosh, you know, I know who has ribbons in South Florida. Would you mind dropping one off or leaving it at the cancer center so this patient can pick it up? Getting people connected all the time. You can really get creative, and Amazon sells sprinkler flags for like $9 for 100 of them. And you can have one ribbon on a stake and put a little display out, or pinwheels. I haven't tried that yet, but I think I'm going to this year. And this is kind of what it could look like. The University of Colorado, who didn't want to light their building up white in the beginning, now does anything we want them to do. But we have some help. You know, you need to make inroads. You have, you know, this amazing panel here can help you make inroads in your center. Talk to them, say, I want to do something. Maybe the White Ribbon Project can help. Maybe we have something creative we want to do that has nothing to do with the White Ribbon Project. That's fine. We got to talk about lung cancer and lung cancer screening. And then we got other states to do it. This is an amazing story. Colette Smith, I don't know if any of you know her, but she's a stage 1 lung cancer survivor for over 10 years. She had no smoking history. It was an accidental catch. And she lives in the Bronx. And she just took this into her, you know, own hands and developed an initiative called Healing the Bronx. And we connected last year, sent her over 100 ribbons. She organized a block party, and it was amazing. They had food, they had entertainment. In the center here, I look at this picture and I always get really excited. This is Penny. She's from Delaware. She drove all the way to New York for this. And that looks like empowerment to me. That doesn't look like shame. You know, let's talk about this. Let's educate the community. Let's get people caught early, because there aren't early symptoms. People have gone to their local businesses. I mean, people say, why aren't you getting Sephora to do something? It's like, well, that's kind of hard. But if I go to the local hair salon where I've gone, you know, many years, or nail salon, here a smoothie, you know, just an independent business, sometimes they're very happy to display the ribbon, put the information up, and then people are finding this, you know, through your own community, which is really, isn't that what this is about? Let's build our community. Let's get support for lung cancer. It shouldn't be the #1 cancer killer and the least funded. There's things we can do. So, things we can do. You know, we look at advocacy as a spectrum. There are some people who, like, I never dreamt that I would jump in with both feet like this, and Pierre and I would be working 100 hours a week on this. And then there's people who are really wanting to do something, but they don't know where to begin, or they're sick. They really can't get out of bed. But could you press a button to help fund, to help increase lung cancer research funding? GO2 makes this really easy for us in the voter voice. And look what happened, you know, in 2025, we lost all funding from the lung cancer research program. Your voices were heard. This got restored, not completely, to 20 million. I know there's still some things that need to be worked out with this, but your voices are being heard. And we can keep going. If you want to do more, you can go to the Voices Summit, which is, I think, late February next year or very early March, and literally be trained to speak to your legislators in Washington, D.C. If that's not in your, you know, logistics, it's not, you know, possible, your calendar, it's you're not feeling well, there are the voter voice platforms that GO2 has on their website. Look at the success now. After what, about over a decade, Danielle, of hard work? Yeah, to get the Women in Lung Cancer Research and Preventative Services Act passed by the House and the Senate. It's still got a little ways to go. We need a little more push. So go to their website, fill this out again. And I know you're all in Florida, so you're all sending to the same people, most of you. Send it to your networks, to your friends and family that live in other places. All of our representatives need to know we want this. We want more funding. And our local, this is my cancer center where I had my radiation treatments. Boy, they put a big old spotlight up there now. That's going to go up on August 1st. August 1st is World Lung Cancer Day. Tell all your friends and family to talk about lung cancer. November is the awareness month. And they host now, they do, it's not dinner, but it's a heavy hors d'oeuvre evening. And we wait till it gets dark, and then we all go out. We had the mayor of Lone Tree out there. A councilwoman has lung cancer, stage 4, recently diagnosed. There's tons of support. The administrators are there. It's a really nice evening. And we had, I think that evening, for over 100 people. This thing started with a breakfast with 20 people back in 2021. We have a bookmark program now. You can take a look on for radon, and so we're working with several states. If anyone's interested in getting this off the ground, it's much easier than you think. We help you with kind of the template of how this goes. You can contact your library system, and you know, we get these things printed. They're not very expensive, and they're courier systems in most states. We'll deliver them to every library in the state for free. End Lung Cancer Now. I can't take enough time to talk about this initiative out of Indiana University Comprehensive Cancer Center. This is an initiative led by Dr. Nasser Hanna and Mackenzie White, who is his executive director. I don't know of any cancer center doing more work than they are right now. They have squads for prevention, for research, for awareness, you name it, and they're getting in the Indianapolis 500 parade every year. This started last year. We were invited this year and went. I can't tell you how amazing it was to walk with these ribbons, and people in the stands, over 200,000 spectators. You walk by, the PA is going on about lung cancer screening, and they're standing up, cheering and clapping. Don't tell me there's no support for lung cancer. We just got to get people comfortable talking about it. This is amazing. And this is really amazing. Every day for years, I'm Googling current lung cancer stories, national, stories. Nothing, or once in a while. It's like pulling teeth. Just this month, I can't even keep up. I mean, this was like within 1 week. This is People magazine. Keep Googling this stuff. You're going to find stuff. This man was 100 years old. He just celebrated his 100th birthday, was diagnosed stage 4 at age 96, figured, okay, I'm just done. And they were like, well, no, you can try this immunotherapy. He's no evidence of disease now since he's 98. There's hope. USA Today, profiling stories. Young women, what's going on here? People need to know this. Young women without any smoking histories are getting lung cancer, all late stage, mostly diagnosed. New York Times, we've got a couple of reporters who are really friendly to wanting to spread lung cancer awareness now. Man, they are doing a great job, and they're bringing up things that really need to be brought up. Lung cancer screening, the shame of stigma. People who smoke, they don't deserve this either. They need to know they are worthy of getting screened. These are important news outlets. And just yesterday, morning, this was from, I think, St. Louis. And there was another one today when I was sitting at the table. We just keep finding stories, and these are in the news. Good Morning America has been really friendly to this lately. Will Reeve, I don't know if you remember, he's an anchor. He was the young boy who lost his father, Superman, after he was a quadriplegic, and then shortly after, I think maybe 2 years later, his mother, at 42 years old, died of stage 4 lung cancer. And he was orphaned, and now he's an anchor on Good Morning America. He's embracing these stories, the new faces of lung cancer. Now we have another story just about a week ago about a new protein that they could be following, and this could be a real game changer. And the Susan Wojcicki Foundation just launched, and this is going to be perhaps our Susan G. Komen for lung cancer. This is a big deal. Follow this story. And the Today Show as well. So what was like a desert of awareness in the media has now become quite flooded. We need more, and we'll keep watching it and keep promoting it. Share it with your friends. And the White Ribbon Project, we just want to let you know, we're just all about collaboration. We want to work with everyone who, wants to do positive advocacy. We don't want to shame people. We want everybody to get screened who's eligible. We want screening expanded to those who currently aren't eligible, but it's not going to get there if we're not all on the same team. We really need to do that together. And we love all of the advocacy organizations, and we also encourage people to get involved with advocacy within your own boundaries. We never want people to feel pressured to do something they're not comfortable with. This kind of naturally evolved for us, but we don't expect people to work these many hours. If it's pressing a share button on a social media post, that's very valuable and important. It gets the word out. And look at your skill set. Look at what you like to do. And then, let's talk. We have calls with people all the time, figuring out new ways, creative ways to get involved and spread the word. And this is what you'll find on our website when you go to community. So when people find that one pager and scan it, they know how to find their community. So this is us again. Everyone belongs. Doesn't matter your stage, smoking history, whether you've lost a loved one and you're patient, your loved one has passed. We need everybody in this. Industry partners, the science community, our medical teams. Just like HIV and breast cancer was, if we all work together, we're going to be a much more powerful team. We have these monthly Zoom calls. Our next one is this Saturday from 12 to 1 p.m. Eastern Time. We'd love to have you on. There's usually a subject matter expert giving a talk and letting us know what's hopeful. And then we brainstorm about what we can keep doing. You can find the link on our website. These are our social media handles. I'm just a little old lady who's trying to manage these right now, so I'm not as quick, but we've been doing pretty well on Instagram and Facebook lately, and our website. And thank you. I shared with you a picture of my family in the very beginning. There were no grandbabies. I have 3 now and another one on the way. So thank you, multidisciplinary teams, for treating us with the best technology and such respect and love and care so we can keep going. Thank you.
Thank you. Thank you so much, Heidi, and thank you, Pierre. And please don't forget, you can fight over the ones on your table, but there's plenty more in the back. And one of the things I love most about this and that I've seen since the White Ribbon Project came into my life, or GO2's life, is how people use them as sort of autograph books, if you will. So as people meet other people living with lung cancer, their care teams, they have them sign little messages of hope on the back. And I have one in my very own office that has been signed by many, many people. So it's really, really a beautiful thing. So thank you both for sharing your work. Thank you to this team. Dr. Raez for moderating this incredible team from Memorial Cancer Institute. It is an absolute pleasure to come down here every year and to work with you throughout the year when we're not here. I just think the world of you guys, as I know your patient community does. I want to give a special shout out to the Hollywood Beach Marriott staff for everything tonight. Yeah. Team Unity Media, they're in the back and around the room for being able to video this and bring it to people in their own homes, wherever they may be around the country or even around the world. Thank you to them. Michelle Zay and Haya Estrin over here, my other GO2 team colleagues. Michelle's been moderating the online conversation, so the people that have been watching live online. Thank you to both of you for being here and supporting this. Onyx and Ash. Most importantly, thank you to all of you in the room. We do this type of programming for you, and we take requests. So if there's a topic that you would like to hear about, just let us know. But we really do. We want to bring you, like I said at the early onset of this meeting, live and in real time conversations with your providers, where you can ask questions like we're asked in the room, the questions that are deeply meaningful to you as you're walking through this lived experience. So thank you to all of you in the room and all of you watching live. Our next lung cancer living room is the best of ASCO. So some of you may or may not know the American Society of Clinical Oncology had its big annual meeting a few weeks ago now. And we're going to be reporting out on, what's the date, Michelle? July 21st, sorry, thank you. And all of you here in Florida, feel free to sign into our live stream. But we're going to be going over the highlights, what came out of ASCO as it relates specifically to lung cancer. Lots of exciting things to report out on, and that will be with Dr. Kyle Concannon from Colorado University. Last but absolutely not least are our presenting sponsors. Without their support, we absolutely would not be able to bring this programming to you. So AbbVie, Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Ionis Foundation Medicine, Genentech, Johnson & Johnson, Lilly, Merck, Novacure, Nuvation Bio, my Nuvation Bio friends were here this evening, Regeneron, Revolution Medicine, Regal, and Summit Therapeutics. That's a long list, which shows the commitment from our industry partners to being able to support our patient community. So thank you all again so much. We'll be talking soon. Thanks, everybody.
So I'll be brave if you're brave. I'll be brave, but only